Hi, everyone. This is the Patient is Knocking panel. It's a nice way of just kind of framing the patient request in care quality. So, of course, patient request has been supported for some time, but as you've been hearing throughout the day, we want to spur on more response. So, in recent, like last 6 months or so, the framework policies document in care quality has gotten passed through. For those of you who were here last year, that was this big piece of policy internal to care quality that allowed us to expand on the flow for patient request, along with a bunch of other policy things. That particular document, it's over all of our use cases, which in care quality is a capital U, capital C, covers treatment, covers fire, covers the regular kind of exchange that we have now, the IHE profiles. And so what it created was this flow. You heard previously that identification is one of the key focuses when it comes to patient request. So we heard from our implementers that they wanted to make sure that they could verify on the responder end that a process had taken place to identify the patient. And we're identifying to IAL2 and also have an AAL2 component. But I know this particular audience may not be as in depth with the technical things, but the fundamental thing to understand is that from the initiator, so that could be a patient app, that could be all sorts of different actors, they can verify with a CSP, which is a credentialing service provider, to IAL2. That CSP will pass a secure token that they've signed, along with some verified identifier traits. So that gets passed down to the initiator, who will then take that token and send it to the responder, along with their normal request. Now, why is this important? Verifying a patient allows the responder to know that the individual initiating is reasonably the person that is the patient and that they should be responding to. Once the responder receives that token, they have the choice of what to do with it. They just can't break, which is important. But generally speaking, if they do want to actually interrogate that token, they get a list of information, so demographics that have been verified that they can then use for matching. They get a match. The flow kind of works like normal, classic Coke care quality. This is the bland, boring part. We're getting to the fun part. So as much as I'm already interrupting your lunch, we'll get to the panel now. So you now have a little bit of a table set of where we are and what we're even doing. We have an amazing panel, and they represent some of the organizations engaged in our early adopters group. So, like I mentioned, everything that we're talking about with patient access has already been approved by care quality, by the community, by our steering committee, by our advisory council. This is live and ready for production. So what we are doing now as an organization is getting groups together that are interested in exchange for patient request that will be our early adopters, and going forward, they will be the ones at kind of the vanguard of what we're doing with patient request. So, all that said, we're really happy they're willing to participate. Thanks. Great. So, what we'll be talking about is just where we think we are, where we'd like to be, and what we think of patient access generally within care quality. So, panel. Hi, everyone. So it's going to be a little bit less formal than some of the other ones, just because I don't want to bore all of you with what we normally do in a work group. So I guess just kind of starting out, we've had a series of meetings. We have 5 initiators, for responders. We've done surveys of that early adopter group to figure out where the overlap is between the initiators' patient population and the responders' patient population. Looks like we're going to start in Connecticut, so anybody in Connecticut that wants to be guinea pig's the wrong word, what do we use for, a willing volunteer that wants to advance healthcare. Let us know. You can be involved. We'll give you some apps to download. So that's been a really big step forward for what we've been doing for, 5 years now?
I've done this panel every year since 2018.
She won't let me have it without her anymore, so. But we have been making incremental progress because this is important, as you've heard in previous panels. Not only important to us, but important to patients. So we've talked about what we're doing, and that there's this group of early adopters that's been meeting. What do we think success looks like for our group? Of course, exchange is great, but what do you all think of as success in this context for the early adopter group?
I think before we get into that, I should give a little more background. Is that okay?
Yeah.
So for the audience, if you're not tracking what Chris is saying, basically the ability for consumers to query care quality, to pull their data back, is an optional workflow right now. It has been optional since the inception of care quality. And it's to the point, based off 21st Century Cures at TEFCA, that it needs to move forward. And there's been a lot of conversations over the past 5 years on how it moves forward, what's the technical implementation and the policies around that. What Chris is specifically teeing up right now is that there was a new IG passed, which calls for the addition of a token that essentially secures the demographics, the attributes that are collected when a person goes through an identity proofing event. An identity proofing event is I take my phone, I download one record, I go through the app, and then I take a selfie, biometric combination of strong attributes that track to the NIST digital guidelines. NIST 6300, am I saying that right? Yeah, whatever, we're good. And then from those attributes that have gone through a verified identity proofing vendor, those are the attributes that are used in the patient match in like a traditional document query. In this use case, what we're talking about right now, there are some additional requirements to secure that the attributes are not tampered with. And in the IG that was passed, the second step was we need to launch a pilot. So there's a small group of care quality implementers who have showed up to pilot this use case to show that consumer app can query, pull back records from a responding gateway. So that's why we're here represented on the panel. This is the responding gateway.
I'm the responding gateway.
We only refer to him as the responding gateway.
I am the app. This is also a gateway, gateway and app.
And an app.
The interesting thing, and the thing that I told Chris I was going to be very spicy on this panel, is that the whole thing is there's been so many meetings week over week, year over year about how we can't trust third-party applications, how we can't trust consumers, how we can't trust that the person is who they say they are, right? And we finally got to this point where we've put so much thought into how to actually make this go live on the network, and nobody's even showed up to be part of our pilot. The only data source responder is CRISP. The only HIE, the only person that represents covered entities came to the table.
We do
so
have
right,
one more.
who?
We have Health Gorilla.
Am I going to count you Health Gorilla on this? Okay, Health Gorilla.
Yes, they're
We have Health Gorilla too. We do not have any EHR vendors who came to the table. We do not have any payers that came to the table. We only have Health Gorilla and CRISP, which falls probably more into the HIE QHIN category. So what we're going to talk about is how we hope the pilot will be successful. So every organization in this room, if you're an EHR vendor specifically, you're going to go back to your leadership teams and you're going to say, we need to participate in the phase 2 of this pilot. Here's the data that was collected. Here's the success metrics. And we need to implement this so that we can successfully respond to individual access, both in care quality today or in a future state of participating QHIN that you opt into.
Can I talk? I'm the responding gateway.
Yeah, go ahead.
My
Responding
job is
gateway
usually to say
respond?
patient not found.
He's responding.
He's responding. It's what he does.
Yeah, so for me, I think success is obviously getting across this finish line and actually getting data flowing and putting this long process behind us. But I also think it's important that we understand what patients want from this workflow and that they actually use it. There's sort of a lot of this is being pushed by regulation right now, and I totally understand that. But we really need patients to understand what is the value in downloading a third-party app that's not necessarily tied to my provider to make it sort of successful in the HIE, HIN actor world. It makes sense, obviously, if I go to my doctor that I want my lab result, quickly and can review it and go to WebMD and look up what it means and wait for my doctor to call and get mad at me for doing that. But I want to, as a patient, what value add am I getting to participate with an app that, like OneRecord, like Health Gorilla, like Invitae, to get that extra data from all over the place, right? From multiple health systems is obvious, but what are the value adds of that app ecosystem, and how can we support those things how do we support those things to advance sort of the general idea that the patient should be empowered to drive their healthcare, and just getting your lab result isn't really the only reason to do this. So for success, it's obviously getting this working, but also that patients generally understand why they're using patient apps, and it adds more value than just my lab results get pushed to me.
I will say that success will be that the goalposts stop moving. I remember we hurried up and joined Care Quality through our on-ramp, which is MedAllies, because January 23, everybody was going to be mandated to respond, and then, of course, the goalposts moved. But I will say that we have already demonstrated technical success. So we have the tokens we have to do, and the responders can validate those tokens. But in the meantime, we sent a request through MedAllies, through Care Quality, to CRISP that went to Connie, which is the Connecticut HIE, and we got a CCD back. So we proved that technically the function all works, and that's a valid use case where the token is not validated by the endpoint. So we've already demonstrated some technical success. Now we just have to move forward, finish it with the tokens, and then in showing that, getting other people to participate.
And I think it's really important to point out that you just described success in the world, that this is working. And that's, it's been funny over the 5 years, we've been inching closer and closer to that. And while we do have a couple of new doohickeys attached to it, we're hoping that we can continue that sort of progress, and that's what the kind of move forward with this group will be. And kind of like what we were saying earlier, we hope that you will join us. Any organization will have a call to action slide at the end to encourage all of you to join us. And particularly if you're a responder, get engaged. Because these things are coming in multiple different venues and modes. So getting everybody prepared and getting everybody moving forward is really what we would hope to see. And I know you mentioned the mandatory response part. So of course, when the policy around the token flow was originally proposed, the thought would be that it would be mandatory response if all of the conditions were met. Care Quality takes all of its policy advancement through a process that involves votes from the implementers, feedback from our steering committee, feedback from our advisory council, so that we have assurances that our policies match where our implementers are. So whenever we bring on something like a required response, there's obviously going to be something, particularly if it's something new that we are requiring response from, there's going to be feedback about, is this now where we are from a technical standpoint? Is this where we are from a policy standpoint? Is it where we want to be and all of those sorts of things. Now,
Chris is being politically correct. Let's just get to the chase here. This is the hot topic issue. Nobody wants to approve it. It gets held up every single year.
we're working on it.
That is what he's trying to say in a very nice way. Patient access is the thing that can never seem to get across the finish line. And we're like right almost there. It's like they just ran the New York Marathon and you don't know if they're going to complete it. And you can see it. But the question is, even if we have, the technology's always been there. That's how treatment works today. People can exchange documents at scale. The people who are left out at the table are the people who care is being provided for, right? They can't access their data. The current technical guidelines have added a little bit of an extra barrier for third-party applications with this token. So it's different from everything else in the ecosystem. If I today, Ryan actually called me over the summer. He said, can you connect to us? I couldn't because it wasn't part of my PIs for the year, but that's fine. But if I connected to Ryan today via CRISP, I don't have to do this additional token to make sure the attributes haven't been tampered with. And the reason why this is a point of contention is because there's less than 5 vendors in the market who've gotten what we call Contera certified. And of those 5 vendors, only 2 vendors can really even support this token. So what we're entering into the market with is a limitation on service vendors for the identity proofing. We're entering into the pilot with very few responding gateways. And we've created these additional requirements that might only exist within care quality. Maybe they'll exist in TEFCA, please don't put them in TEFCA. And maybe the HIEs who are named actors under information blocking won't implement it for themselves, right? So me as a third-party application are gonna be dealing with multiple different ways that I have to verify a person is who they say they are, depending on which way I try and query to get records. This is very different from how you maybe have experienced getting your records, where you log into a patient portal or you download an Apple and you connect via Fire API. This is a trust problem and where we don't trust third-party applications or patients that we aren't going to expose the wrong person in a patient match. That's what it comes down to. It's also a liability, right? The vendors who participate within care quality feel a liability that if they expose the wrong data to the wrong person through a third-party app, what is their liabilities? If I was running the government, I would maybe suggest some sort of, safe harbor for this use case or some sort of exception. I don't know. That's how I think about it.
So there is, and the safe harbor you're mentioning is because there's an inherent difference between
Exception, not
yeah.
safe harbor, exception.
exception. So it's that tension of there being an inherent difference between accidentally divulging information to another covered entity versus divulging it to a consumer.
Who's the data's about them.
Assuming it's his.
So I might go off your HIE point there.
Okay, thank you.
So it's a should in care quality, but
Right.
for HIEs, it's not really a should. It's you have to. And certainly there are HIEs who have contracts with their participants that they believe prevent them from doing that. For us, we're not in that position. Our contracts are very clear that this is supported. And so we must. And for us, there's no other option really than to use care quality for this because it's been vetted. All of you are part of care quality. It's an all in this together type thing. We're not going on our own. We continue to be vendor agnostic, which is really important for our health data utility, is to not pick a winner, to not pick a vendor, make sure patients can use the apps that are out there in the marketplace. And so we really believe that this should be what HIEs do for patient access. And it's actually, as Jenny said, it's easy. It's the same as treatment for our side as the responding gateway to just respond. We don't have, obviously, the token stuff. We may validate the token that we get. It's an option in the implementation guide. But my soapbox on this is a lot of you have to do patient access. You're either justifiably avoiding it because of actual legal issues, or you're kind of just ignoring it for now, hoping it becomes obvious what you should do. This, to me, is what you should do because we've all kind of vetted it. It's actually pretty easy to do. We've already proven we can do it in a test environment. And so my push is for that. I would say the HIEs, the HDUs also have the added capability to educate the provider and patients in their local communities to say, yes, your data is available through the HIE, but here's what you should consider when you're picking an application to query the network, because it's a little bit scary to download an app on your phone for a lot of us who aren't as tech savvy, and to know what you're signing up for and what you're not signing up for. And so our Connecticut HIE partners are putting together an awesome FAQ. You know, when you're considering accessing your data, this is what you're doing. Be careful, read the language. You know, you're waiving some of the sort of inborn provider-to-provider rights you have with protecting your health data and all of that. So it's also a good education opportunity for HIEs to actually talk to the consumers, the patients who typically have not been at the table for a lot of us, and educate them on why this is good, why this is important, and how you should do it. And so I may be in the minority in the HDU community on that, but hoping to convince at least a couple others to join in.
To what Ryan's saying, I also think 5 years on this panel, we're also what I consider, you know, there's the BC before COVID and AC after COVID era. There were so many people who downloaded apps to get their vaccinations, right? People know how to choose apps now. It's their choice to download which app, which service to get their data. So I think that's also, we were dealing a lot with this kind of paternalistic mentality around, well, can consumers actually pick which app they should use, and is the app safe? If you listen to Mickey talk, it's very clear. We're talking about patient access, we're talking about transparency and AI, and we have to give consumers not only the choice of the app, but also the choice of the way they want to get their data, whether that's walking into the HIM department to get their medical records, whether they're logging into the patient portal that's tethered to their EHR that their provider uses, whether they're choosing a third-party app and they're going through an OAuth workflow to pull through a FHIR API. This is just the next step, and this is the best step. And it's the best step because it doesn't require the patient to remember where they received care. It allows them to query and pull back all their records across all their care organizations, and then the app or service is going to provide the value to that person, whether they're seeking a diagnosis or they're trying to manage the care of themselves and their loved ones and their kids, that sandwich generation between their kids and their parents, right? Everything that you heard on the Consumer Voices panel, you are all patients. You all will need a service like this one day when a big event happens in your life.
It's very challenging to be a patient in healthcare, obviously. Like it's mostly miserable, right? And I think this is an opportunity for all of us who are technologists to actually make it easier for patients to interact with healthcare sort of directly. You know, there are lots of things we're doing in the healthcare systems we work to try and ease the burden on doctors and ease the burden on patients, but in the end, they're waiting in the emergency room for a long time, et cetera. We sort of have an obligation to make this easier than it is to get your credit report, right? Where you have to go to 3 different places and fill out all these forms all the time and then see if they're the same, and each one is interpreted differently. How do we make the sign up for this more of a one-stop place where it's easier for the patient to understand what's going on, and do what we can as technology people to actually make a direct impact on making this a little easier for patients, knowing we can't control a lot of what the providers do, in my view. So I think we have an obligation to do that, and this is a great way to do it, sort of through this sort of common everybody together.
It's also a double,
No.
oh, sorry, go ahead.
I was just saying, not only does it have to be simple and easy, but it has to work, right? You're not going to get too many chances of patients trying this and not getting their records back and coming back. Obviously, with very sick patients, they're highly motivated. They'll try and try and try. But the average population is not going to give it multiple tries if they sign on with their app of choice and they don't get the records when they request them. So I just want to add, you know, I complained about the goalposts moving. This latest one was adding a token. But there's actually a silver lining to that. Not only does it make more participants be willing to participate, but there's a little, the AAL2, which is basically certifying the multi-factor authentication piece, often will end up making the patient's cell phone number a verified piece of information. Why that's important is that for these credentialing service providers, the ID.me's and Persona and Clear and so on, they get their data from a driver's license or a passport. Those typically don't have your cell phone number on it. The challenge is you can only submit verified credentials across the network to be able to get a match and have the data come back. So people who have moved and their addresses are a mismatch or other things make the system fragile. Now with this additional thing where we can utilize the cell phone as one of the verified credential, that's probably the best single identifier in healthcare today, right? Just as good as the social security number, maybe better. So there was a benefit to moving the goalpost, requiring AAL2 and having that.
So I think that's a good point. I do think, and and I made a joke earlier, I'm the responding gateway, so my job is to say patient not found. I do think that's an issue, right? Like you could easily block this up by just turning your matching algorithm to be super deterministic, and any stray is a patient not found because I'm concerned of doing the wrong patient. And I do think, last time I spoke at a Sequoia meeting was about a patient matching framework we had put together many years ago. And that problem is still a problem, right? And so collectively, we also need to figure out, are there other pieces of verified demographics that will make this matching happen at more scale? And how do we come together to actually ensure that patients aren't frustrated that they went through this whole process to download an app and it says there's nothing available?
So to what Ryan's saying, first of all, if it's not clear, I hate the token with a passion. I don't think it should be in the spec. If you think about this from a developer perspective, I have to go out, contract with a third-party identity proofing vendor. Then I have to install it, put it into my workflow. Consumers have to run through it. Even if the consumer is successful in going through the identity proofing event, getting the verified attributes, sending them in the token, there's still a high probability that there's not going to be a patient match, because it's going to determine, is that patient represented within that gateway, this gateway, or any other gateways that potentially would query. If you don't have any other organizations showing up for the pilot or future pilots, this fails anyway. So all you did was create a higher bar for one side, the patients, and there's nobody on the other side to even respond to it. I am more optimistic about the HIEs responding to patient access because they're named actors under information blocking. It's cert technology vendors, HIEs, and providers, right? I'm a little less optimistic about the EHR vendors. The EHR vendors who have historically participated within care quality in responding, because if they were going to participate, they would be in the pilot. So that is my call to action for anyone in the room. I expect you to show up to the pilot.
If you haven't noticed, we are trying to really advertise this pilot. And we'd very much like anyone that can act in a responder role to engage with us and participate.
And the thing is, this is a perfect opportunity to prep for TEFCA, right? Like, this is it's a small group. There's only a couple of apps. We can control everything about this pilot, and then you can use those data points for when you join a QHIN, and it's mandatory if you're going to participate under treatment, you're going to have to respond for IAS, and that is patient request.
And we had discussions about the pilot verbiage, because an important thing that we're talking about here is production exchange. The policy has been passed. This is a thing that exists in care quality today. So we can use pilot, we can use early adopter, but the fact of the matter is, this is a thing that is available today. And the only thing holding us back is having responders there. It's that next leap. We've made, even if we don't love the token, we've made the most secure thing that we possibly could. We've heard feedback from the implementer community and adjusted the policy accordingly. We feel that the conditions are right for even those that are a little bit more bullish on patient requests to come join us with the early adopter group, and we can show the community generally that this can be done, just as you guys did.
So Invitae is a very good example. They've built a gateway where they're going out and connecting to a bunch of HIEs where I can connect to them to then do individual access, right? I really believe the HIEs are in a better position right now to respond to individual access. What I'm concerned about is TEFCA goes live, you have QHINs, you have the QHINs participants onboarding, and that the provider organizations just opt out of individual access. So the capabilities there, but provider organizations, and some of you are in the room, are just not going to respond. So then the default workflow for consumers is just going to be the FHIR APIs with the OAuth workflow, and that is still a huge burden for consumers because they have to remember every single place they've received care. They have to redo their passwords. They have to do all these things. And beyond the top 10 vendors who nailed their FHIR APIs, there's still 190 vendors in the market who do not have production-ready APIs. So there's still this huge gap in me being able to consolidate and get all my records in one place.
So we talked a bit about how response and care quality is a should, not a requirement at the moment. It was what we initially tried to go for, like I mentioned, was a required response. And the hope would be that this is proving out through the early adopter group that we can get there. I know this is a biased panel, not so purposely, kind of purposely so. But what obstacles do you see going forward for us as an early adopter group that we'll get answers to as we're going forward?
The first one is that, I think we already mentioned it, but the CSPs, only a few of them, very few of them, are already committed to producing the tokens coming back, and some of them are saying, yeah, we'll do it, but we won't have it until Q1, and some later than that. So that's a challenge, depending on which CSP the personal health app is connected to and getting the patient verified for. So just a delay.
For me, it's, we turn it on and it turns out the patient's not knocking. It's just regulators that are knocking. And no one cares, right? Like we have experience fronting FHIR APIs for the patient to payer for Medicare, Medicaid. And while that has been a great exercise to actually build a framework for FHIR APIs that when we get to payer are going to be like, I think, used a lot. But the marketing in some of these states that your Medicaid data is available from a patient app is not there, or there's no money for it, or whatever the reason is. And so there just isn't a lot of utilization. And so back to my original point, there needs to be, why as a patient should I do this? And we need to be able to prove the value. And so for me, the risk is that we do all of this setup and we get 1% of patients, less than 1% of patients who actually care about it. And that would be a disservice.
I kind of disagree with you. So patient portal adoption is probably less than 2%, if there's any patient portal numbers that people know better than me, but I think that's like what you see, or member portals too, right? So if you get 2% adoption, you are at the same as any sort of tethered application to some sort of source system, right? To the CMS patient access API's point, the failure in that reg is that it's not the commercial lines of business, right? So what I'd say is if we can get the California HIEs to participate in the pilot at the same go live date as all the commercial lines of business have to go live for those APIs, most of the people that come through One Record, they fail when they're trying to pull their data from the payer APIs because they're commercial lines. They're not Medicare, Medicaid, CHIP, or anything on the ACA. So I don't think that's the best data point for this, because that also isn't, I think it's harder for consumers to understand why they want maybe their claims, their financial data and their clinical data from their payer. I think it's very clear, I want to get my records from these providers. That's really hard from a messaging perspective.
Yeah, but for me, like that patient population, and not to debate the Medicaid, Medicare stuff, but the patient population there is in more places, likely to have their data in more disparate systems, much more in need of care coordination, probably has someone who's trying to be the custodian for their records, and I think there needs to be some messaging to figure out how can we better engage that population, because they are all over the place. And for Medicaid or Medicare patient, the vast majority of their data is going to be in that API, even if it's claims data, even if it's not real time, et cetera. But again, that's a little bit of an aside.
I think for the clinical data, the real thing is going to be if you have the big tech companies, Apple, Google, Apple Health. If Apple Health could potentially do this workflow, I mean, they're in the hands of almost probably everybody in this room, right? So until we have organizations who have scale querying, you can't just question whether or not the patient is going to knock, because they are. Thank you, Grace. I see you. Grace is shaking her head. So should we open it for questions?
Let me see. Oh, one more desperate plea for volunteers. So, again, we have this early adopter group going. Please send a message to admin@carequality.org. And do let us know if you're interested in being a responder, an initiator, or both. And also how you're connected to care quality. So we're pretty much taking all comers so long as they're connected. If you're not connected already, that's maybe more of a discussion to make sure that you're onboarding, whether you're going through a service provider or you're becoming an implementer in your own right, matches up with our timelines. But generally speaking, if you're out there and you're interested, we're interested. Let's see what we can do. And with that, question time. You have a little under 9 minutes to berate us.
Oh, good, we got questions.
Hit it. Yeah, there you go.
Question and a comment. Okay, so can you give me, or can someone give me, an estimated prevalence of the rate of improper disclosures that everyone is so petrified about? Help me understand, is it every transaction? Is it every request is going to be peppered with errors and it's going to be a HIPAA violation? Or for every 100 IAS requests, is 5 of them going to be impacted?
Do you want me to just...
Can I take a step?
Yeah, go for it.
So we're relatively recently connected doing these patient requests through Care Quality. But for a while before that, we were doing the same requests through our private network connecting to HIEs. And the answer, I don't know what the exact answer is, but the answer is it's on the small side. But the problem is one's too many, right? But what happens more than the wrong patient getting identified, we found exactly one time in our history where we actually connected to the wrong patient. But what happens more often than not is patient not found, when in fact the patient absolutely knows they have data at the place that's coming back, and you tell them no data found, and it's terribly frustrating. So you want it to err on the side of getting them their data, with the one caveat that there's no safe harbor yet for sending the wrong data to the wrong, or sending somebody else's data to a different patient.
Okay, but we do have AI, and maybe we can take a clinical summary and we can use AI to scan it, and maybe we can make patients involved in the process to curate and see if there's a flag, and if they want to withhold that data. Like, there's a lot of solutions that we could try instead of saying, no, we can't do it. And I'm going to double down on my 911 effort. When you call 911, you're not worried if the person's going to do exactly what you need to do to save you. Your building's burning down, and you're going to take whatever help you can get. So I'm going to encourage everyone to think sort of through that lens and participate in this pilot to get things moving. And then my other comment is, I feel like I have a problem with the problem statement, that patients don't care about IA, the concept, like, do patients care about IAS? Patients don't care about IAS. They care about enrolling in a trial. They care about securing Social Security benefits. They care about making an educated, informed decision about life or death for their loved one. They care about demonstrating medical necessity to their payer. So I think we need to shift the way that we're looking. How can IAS provide value? And then to the previous comment about ROI, there is ROI. We have to tie this to the incentives in a very clear line, and I don't feel that we have that. So it's still like this gray area, nice to have. There's money involved here too that can provide value for participating in this. I just think we have to collaborate on that.
I believe that patients will use this workflow, without a doubt. I know why patients will use it, because we built, Eric Heflin wrote the original patient access spec. We implemented it when we went live in 2018. It didn't have IAL2. It had something called KBV, which is called knowledge-based verification. And I've never taken it. It's kind of hidden in the app. I've never taken it out. And what I do is I keep it there so that people click on it to see if they can go through the workflow. And I've used it as a data point to see how many users are going to go through our app, like try every way to get their data and still find this one way. And so every day I see these little transactions going through where we're not querying, it's just a user trying to query the networks. So I know users will do this, and it's not the first thing that you do within our app. The first thing you do in our app is we push you through an OAuth FHIR workflow. And then we say, oh, we can't find your care location because that EHR vendor didn't publish their FHIR server URLs, hint, hint. And then we'll say, try our partner networks, and there'll be this little button and they can try and query. So I know users will do this. It's the question Ryan is asking at scale. What scale?
Yeah.
And you're pointing to, if you tie it to use cases, people will use it at scale. Next question.
Yeah, Grace did a great job of where I want to go to. It feels like the demonstration project. I'm glad you think everybody's going to come, but how do we infuse some player in the demonstration project that's getting to patients that need their data and not just trying to broadly spray patients in an HIE?
I guess we could work with Grace and get a group of people together.
I mean, I think you have to find a provider, some
Yeah.
kind of health system, an emergency department, an urgent care, something that is identifying patients.
If you're a
I'm-
provider.
Yeah, I already wrote it down. But I just want to point, I think Grace is making an awesome point. And if we really want to see if patients are going to use it, we need to find a way to get to patients that need it as part of our demonstration project.
Well, the only failure to that is if we only have one responder that only represents a certain geographic region.
Right.
Then we have to find people within that geographic region who are also going to be a patient match. So we've already limited the scope of the pilot.
Yeah, so it's
Stanford Healthcare?
yeah. One of the first things we did was to put out a survey to the participants.
Hey,
Yep.
Ryan's got a question. We only have 5 minutes.
Oh, yeah, and I can
Finish your
babble.
thought, Chris. Go ahead.
Oh, no, it was just to say that finding that overlap was one of the key things that we had to do, and anytime we bring on another group, that could maybe change that calculus. So, and just generally speaking, we want to expand. So, all comers.
So I want to be positive, all right? Very excited that this is final in care equality. As you know, Care and Alliance worked on this for the last 5 years, and we piloted this with 30 organizations last year, and it does work at scale. So we're super excited that Care Equality and Sequoia are now adopting this. I think that's point number one. Point number two is there's a fallacy out there, even among folks in this room that know this stuff cold, that these apps are shady and they don't follow certain protocols. Folks are forgetting two things. One, according to TEFCA, if you're an IAS provider and you're participating in TEFCA, you have to follow HIPAA privacy and security rules because TEFCA is voluntary, okay? So that's number one. Number two, all of these apps that are connecting to FHIR APIs, they've signed the Care and Code of Conduct as well. And they're also, we now have a certification program. So your data is now more secure in the apps than it is in HIPAA, okay? So I want to make sure that's maybe a spicy take, but that is actually true. So if they are in TEFCA and they're following the Care and Code of Conduct, you have more consent-based, privacy-based protocols than you have today. To Jennifer's point, the other important thing is they're now identity-proofed at an identity assurance level that far exceeds anything in healthcare, anything in financial services,
Yeah.
anything that we have anywhere other than mobile driver's license and going through TSA. So if it's good enough for a terrorist watch list, I think it's good enough for healthcare. Right?
And I think that
So
that's
let me just finish one last point. Just now I'm on a roll. Sorry. I
We only got 2 minutes.
I know it's 5 minutes off.
I'm looking at the clock.
Yeah.
Last thing I'll say is I think it's super important. There are some significant concerns associated with potentially a wrong match. But we have to rethink that. We have to say to ourselves, the reason we have a patient matching problem is because we've never included the patient in any of those conversations. We're talking to health, thank you, Grace. We've talking to health systems now who they've said, good grief, if you're doing identity proofing and mobile driver's licenses, we might as well just use your source of truth rather than the garbage we've got because we're just comparing garbage with garbage. Let's figure that out. Like, let's update our data with the data the patient's giving me because the patient is the source of truth in healthcare. Now I'm done. Thank you for the
What Ryan said.
And the only thing I would say is it is on us, especially in the HIE community, to make sure patients understand everything you just said. Because they're not, where are they going to read that this is more secure, that this is better, that this is HIPAA covered? As my colleague Kate was saying yesterday, there are people who don't have any idea what HIPAA does and spell it wrong. And I think it's our job to make sure patients want to do this, and part of that is communicating that message. And to date, I have not seen that.
Okay, we are
I
negative.
think we should keep going.
Well, no one's come in with a hook, so anyone?
We have more questions.
Yeah.
Do we want to keep going?
Oh, no,
No.
we're getting a,
We're getting the wrap up.
They want us out. Okay,
oh, they want us
bye.
out. Oh, there's a, okay.
They're wheeling the gong out.
We gotta go.
We're out.
We'll never get home.
Thank you.
Thank you.